All right, we are live.
Good morning, everyone. This is the Senate Health and Welfare Committee, and it is Thursday, January 21st. So we are fortunate today to have Nolan Langwell of the Joint Fiscal Office to give us some updates on, or some basic information on healthcare. So Healthcare 101. And Nolan, do we have something online from you on our webpage? We do. Okay, so
Yes.
why don't you introduce yourself, and are you going to share screen
Yeah.
and put it up?
Oh,
Okay.
Nellie, can you give me access?
You should have it now.
All right. Sorry. Oops.
And Nolan, just let us know if you do you want to be interrupted?
I think that's fine. I'll if that's okay with you, I think it's fine.
Yeah.
Okay. For the record, Nolan Langwell, the Joint Fiscal Office. I will say though that I don't the way that the screen. First of all, can everybody see the presentation?
It's good.
Okay.
Yes.
I can't always see people's hands.
Well, so here's what we'll do. I think I can see most everybody, but I think if folks have a question, just to say you have a question, we're a
Okay.
small group and we know each other. So
Okay.
if there's anything, if we need to, I can just say who's first and who's second. But why don't we just go ahead with that?
Okay. I sometimes can. One thing I cannot see is the chats. And I know folks in the house really love to use the chat. But when I'm using this up and they ask questions in the chat, I can't see that at all. So again, this is a
Okay.
small group. So I would encourage people not to use the chat for questions they have for me. You can use the chat obviously for anything else you want to. So again, for the record, Nolan Langwell, the Joint Fiscal Office. What I have here is this presentation that I do every biennium, and I do this for multiple committees. It's 60 slides. I'm not going to go through every slide. It's really meant to be a primer and a reference document for folks to be able to like have, or with whether they have a hard copy, which I usually give people hard copies of this when we're in the State House, or to go back if they just want to know some random numbers. But some slides I'll spend some time on, and other slides I'm just going to pass through, or literally ignore, or just blow through. So because we only have 2 hours and we can easily go off on in multiple directions in that time. Actually, it's really 1 hour with a 1 hour break with Secretary Smith, and then another hour. So that said, the idea behind this, well, actually, let me give my quick disclaimer. Whenever we do any presentation, we always try to use the most up-to-date data that I can. I also feel like I have to not only say that because the data is all over the place. Sometimes you'll see data might be 2015, sometimes it might be 2018, sometimes it might be 2020. It depends on what data I'm using and where it's from. So, and I usually always try to put the year that the data is in there. But I just want to sort of highlight that so that people are aware of that. The other thing I'm going to have to say is that like all this data is pre-COVID. So when I talk about spending in Vermont, or the number of people that don't have insurance, or number of people, like that's all pre-COVID, and the world has changed, and we don't know how those changes have affected enrollment rates in different Medicaid, Medicare, private insurance. We don't know how it's affected spending in the long run yet. So I just feel like I have to sort of say that as a caveat. That said, this still gives you a sense of how Vermont, what our baseline usually is. So I break this up into 4 different pieces where I'll talk a little bit about patients, and then go into providers, payers, and then just a very small section of regulators. So we'll start with patients. I always put this slide in because I think this is a really important piece. We talk about how prior to the COVID refugees, how Vermont has had a very low population growth, and also and you can see it's the change from the 10-year period between 2008 and 2018. The average yearly change was 0.03%. And then if you look in the next one, you can see that we actually have less births and more deaths. So as a result, you can see it's an aging population. So that's an important piece when we think about what the future of our healthcare system looks like, and what are some of the, this is an example of one of the many drivers of our health system, and costs and utilization. And so what this slide shows, and this is all from the, actually I've stole this from the Tech Structure Commission, but you can see our 18 to 24 has sort of been sort of flat, and is estimated to, or was estimated to be flat prior to this is all pre-COVID projections. You can see that our 25 to 64 has kind of gone down. Our 0 to 17 is going down, but our 65 and over is going up. So this is a nice illustration of how we have an aging population in Vermont. And as such, you can see that the causes of death correspond with those particular pieces, where younger folks tend to have a higher rate of death. The higher prevalence of death is usually accidents or suicide, or with older folks, it's usually heart disease, tumors, cancer, stroke, etc. as you get older. So this is just a comparison, sort of like, what does Vermont's health spending look like relative to the country? So Vermont's total spending, and this is 2018 again, was 6.26 billion. I have to, as another quick aside, there's always a 2-year lag in our expenditure. So I'm using the Vermont Health Care Expenditure Analysis, it's put out by the Green Mountain Care Board. There's a 2-year lag. The federal data is the same way. The National Health Expenditure stuff, they have a 2-year lag also. So the most recent report was was released in March 2020. The next one will probably be released in March 21. So there's a 2-year lag. So this is the most up to date in terms of our expenditures across the board is 18. So that said, Vermont was 6.26 billion. The United States was 3.4 trillion. Our average annual change in that 1-year period was 1.9 versus the US, which is 4.7. And then in a 10-year period, ours was 3.6 versus their 4.4. So you can see that we are growing at a lower rate than the United States. That's a good thing. And same goes for our per capita spending. You can see our per capita spending is just shy of $10,000 per person. The US is over 10,000, 10,640. However,
Go
yes.
ahead. Go with your however. You're probably going to answer the question.
Well, our share of gross domestic product, healthcare as a share of gross domestic product is higher than the national average. So was your question?
Just the total healthcare expenditures in Vermont. For example, our Medicaid waiver may include things that are not included in other parts of the country as healthcare expenditure. Is that something that is here? Is that included here?
It's a good question. That gets into the
waiver issue.
Well, even outside the waiver, I mean, the question might be, would you count, so like our Medicaid spending would count transportation, people using Medicaid dollars to get to the doctor's appointment. Would you count that as healthcare? And that's a great question. I think most states in that particular example would. I think most states who have waivers or similar situations, and use Medicaid dollars for things like transportation probably counted in their healthcare line. But the answer to that question is I'm not sure. It's a great question, but I also think that those particular pieces are a smaller percentage of the health spending. So they're probably just blips in the overall spending, but nonetheless, it's a great point. And one that I really can't answer, because then you could also say, what is counted in the national? Are they counting things that we don't either? Are they counting, so I don't know the answer, but that's a very good point. And I know that like both the folks at the Green Mountain Care Board who do ours and the folks at Agency of Human Services, the Federal Department of Health and Human Services, their economists do the best they can to sort of parse things out, as do the folks at the Green Mountain Care Board. I can't say enough about what a great job the folks at the Green Mountain Care Board do when they put this document up. This is we're really lucky to have it. This is another slide that I stole from them, and this is just showing the health expenditures the growth of our health expenditures, our spending versus growth. So you can see that our spending continues to go up, but our growth rates fluctuate. And then this one is a comparison of our per capita change to the United States. So the United States is the gray and Vermont is the blue. And you can see a sense of like how our per capita has increased relative to the feds. So now I'll move on to providers. And this is all these next slides are just kind of high level overviews to give you a sense of like who is in our healthcare system and what makes up the provider segment of our healthcare system. So here we have, I'll start with hospitals. Hospitals are the biggest part of our healthcare system. They are the largest providers, and they're also the biggest, largest proportion of our spending goes towards hospitals. We have 14 hospitals in Vermont, one of which is a level 1 trauma. That's the University of Vermont Medical Center. We are probably the only state in the country that has all of our hospitals being non-for-profit. Now, granted, we only have 14. In some states, they have more than like Los Angeles probably has more in Los Angeles alone than we do in our whole state. But nonetheless, it's still very unique that all of our hospitals are nonprofit. And you know, our ERs in Vermont saw over 265,000 ER visits in 2018, just to give you a sense of the utilization. Also part of our system is Dartmouth Hitchcock Medical Center. Now, we don't regulate them. They're outside Vermont. So they're sort of this weird anomaly, which I'll get into the next slide, which kind of shows in migration and out migration. But Dartmouth Hitchcock is a big part of our health system. They provide a healthcare services to a significant number of Vermonters. We also have the VA, which is located in White River Junction. And then there's the psychiatric hospitals, which are, you know, Vermont Psychiatric Care Hospital in Berlin and then Brattleboro Retreat. So spending on hospital care for 2018 was $2.27 billion, which accounts for 36% of all the healthcare spending of Vermonters. One thing I'll just say really quick is that whenever I throw these numbers out, the Vermont healthcare expenditure analysis looks at spending in two ways. It looks at spending on behalf of Vermonters, so that would be like, you know, folks, I'm a Vermonter, and you know, I get my care at University of Vermont Medical Center, it counts toward it. If I get my care at Dartmouth Hitchcock, it's counting that. Going out to Vail and I ski and I break my leg, it counts that, because those are costs that are part of the healthcare of Vermonters. And then there's another way of looking at it is how much is spent in health in Vermont and on providers. So that might be, and that would include that wouldn't include Dartmouth Hitchcock, but it would include people from New York that get care at University of Vermont Medical Center, or folks from Albany that go to like Rutland or Bennington. So there's two ways of looking at it. I tend to come at things from the healthcare given on behalf of Vermonters. So when you see those numbers, I'm usually talking, me personally, I'm usually talking about resident spending and not provider spending. And so to that point, you know, approximately 20% of the University of Vermont Medical Center business comes from New York residents, and vice versa. A significant number of Vermonters seek medical care through Dartmouth Hitchcock. So the point of this slide is to really just kind of give you a sense of that in and out migration. You know, Porter, they have quite a bit of in-migration from New York for the newborn delivery. Southwestern Hospital shares a market with Albany. St. Johnsbury sells a market with New Hampshire, et cetera, et cetera. Copley, you know, which is near Stowe, probably sees quite a bit of broken arms and legs from people from Massachusetts and Connecticut and New York. So we also have federally qualified health centers. So this is a very important part of our primary care system, particularly in Vermont. They're a little bit different than hospitals and other providers in that they have a special reimbursement designation from the federal government, and with that comes a larger regulatory burden, which includes over 90 requirements that they have to meet that are tied to maintaining their FQHC status. And as a result, they have a different reimbursement structure through the federal government. You know, the things they have to do, such as like offer certain services that are tied to primary care, such as dental, mental health. They have to be located in an area of high needs. They have to have a patient majority governing board. They have to accept all patients regardless of payer or ability to pay, and offer a sliding fee scale. So that's the example of the type of things they have to do to maintain that. And here we have a map, so we give you a sense of where they are in the state. There's 12 across the state, representing 60, actually more than 60 primary care sites in every county. And in 2019, they served over 187,000 Vermonters. So that's a huge chunk of Vermont. So you can see that they are an important and a large part of our healthcare system. We also have our long-term care. That would be, we have 37 nursing homes, 34 of which participate in Medicaid. And as of 2018, there was approximately 2,978 beds. That number has been decreasing over the time as there's been more and more push for home and community-based services. And we've been seeing more nursing homes close over the last several years or get bought out. So I don't know what the current number is. It likely has not gone up. We also have 10 home health agencies, 15 assisted living residences, 110 residential care homes, 10 hospice programs, and 1 ICF-ID, which stands for Intermediate Care Facilities for Individuals with Intellectual Disabilities. These are generally group homes. Well, this is a group home. We have mental health providers. These providers include our 9 designated agencies. We refer to them as DAs. They provide mental health and developmental disability services. They have let's see, one region has separate, well, one region has a separate DA for mental health and DS. They have 5 specialized service agencies for DS only and 2 specialized service agencies for mental health only. We also have the Brattleboro Retreat and Vermont Psychiatric Care Hospital in Berlin, which I mentioned under hospitals. In the mental health system, we have 187 adult psychiatric inpatient beds across the system. At least there were when I did this presentation. And at the time, this is kind of a snapshot because there were some moving pieces at the time that I was putting this slide together, and I update this, try to update this every year. But there are 45 that are level 1 beds. Level 1 beds are for hospitalization stays for people who are the most acutely distressed and require additional resources. 25 are at the Vermont Psychiatric Care Hospital, 23 are at Rutland Regional Medical Center, and 75 are at Brattleboro Retreat. There's also some at White River Junction. But as of November, and this number has surely changed since I did the slide, 57 of those beds were offline, and the majority of which were at Brattleboro Retreat. So I don't know what the current status is of those beds, but that was the snapshot as of November.
Nolan, when you say offline, do you mean that they weren't being used, or they were incapable of being used for one reason or another, or haven't been?
It's a great question, because when I was told they were offline, I didn't ask that specific question. I just sort of assumed that they meant that they were not being staffed. But that's a great question, because maybe my assumption could be wrong.
Well, I'm sure we'll be hearing about Brattleboro Retreat.
Yes.
We've got reports coming in, and we'll talk with folks.
Yes, you will be hearing a lot about Brattleboro. Yes, Senator Hooker.
So does that then assume that we subtract the 57 from the 187?
Yes.
Okay.
But that's, again, this is a snapshot in time.
Okay.
So, and most of that 57 comes out of the 75 at Brattleboro, or majority of it. So, workforce. Last year, the legislature spent a lot of time on workforce. We have, as of 2018, so there's a Vermont Department of Health has a survey. This survey was from October 2019 or was released in 2019, but it was a 2018 census of providers. There were 2,473 physicians, which translated to 1,368 FTEs. FTEs stands for full-time equivalents, which means that not every physician was working full-time. Another 112 renewed their Vermont licenses. Sorry, another 1,112 renewed their licenses, but were not providing care in Vermont. So that was an interesting fact that I felt like was worth sort of throwing in there. 615 or 25% work primarily in primary care, which is actually 19 fewer than in 2008. 1,858 or 75% worked mainly in specialty care, which was more than in 2008 and 2016. So I put this in here because it just showed that there was a small trend in people in primary care was moving in the wrong direction, or we had less primary care physicians and more specialty care in that time period. Increases were especially large in hospitalists and emergency medicine. I don't know why that's contradictory to what I just said, isn't it? I think the point of this was that just because it was going down, it doesn't mean that all specialties saw decreases. I tried to highlight some of the changes because after last year's, a lot of focus last year on the workforce, I felt that this was important to sort of try to show some of the moving pieces in our workforce. And I do the same here with the nurses. So you can see here.
Hey, Nolan,
Yes.
I would just, this is Ruth. The workforce numbers are surprising to me that we have so many physicians that are not working and not working full time. And given that we have a shortage and in a lot of places, and I'm wondering, does the report speak to that at all? This October 2019 report about the reason why these numbers are the way they are? Is there some kind of professional disincentive, or are these retired doctors who are older, or what is the sort of makeup of that?
That's a great question. So this census is different than the task force report. The task force report may have addressed that. I don't recall if the workforce report addressed that. I suspect some of it is older physicians who or retirees who just want to keep their license up because they practiced for so long and went to school for so long, and maybe they want to do some pro bono work or work in a clinic on their free time or whatever. That would be my first guess. I'm sure there are a lot of other reasons. Maybe they moved out of state, but keep their Vermont license. It's a great question, and I don't recall if the task force report addressed that.
Okay. And
But
do you know, I know that during the pandemic, we've been trying to recruit people to I can't remember what it's called, but the sort of doctor core, the healthcare core. And I wonder how successful that's been, given how many people have licenses that they're not using.
Yeah, I don't know the answer to that either. In addition to that, we also had a bill last year that, was giving more scholarships for our workforce, and I think the committee might find it useful to find out how's that going.
Yeah.
Has it worked? So I think that those are great questions, and I don't know the answers to them.
Nolan, observation that I had here, 615 primary care physicians. That's roughly one doctor per 1,000 Vermonters, if my math is correct. I don't know what the right ratio person to doctor is, but that seems awfully high to me. So that's certainly a concern, I would think, for our medical needs in Vermont.
Yeah, I think you touched upon an important point in the task force document, which was, is trying to recruit more for primary care. I mean, obviously we want to recruit for all the different pieces too, because, I had to go to a dermatologist once and I couldn't get one in Montpelier for 6 months, but I can get one in Burlington in 2 weeks. So,
right.
So we need physicians all across the spectrum, but there has been a particular focus on primary care.
Yeah.
So yeah, I just to chime in on that, you're absolutely right. And so the loan repayment program for healthcare providers, and then the incentives that we put in place for primary care folks last year, all go to drive our goal of having more primary care and prevention efforts for in the state. So, yeah, this is an important issue. We'll circle back to this one at different times, and we will hear from Jen and Katie on some of the bills we passed. So we might touch on this. I think it's Friday. That's tomorrow. Yeah.
Although I think that this particular piece wound up in the budget. So it was started off as a separate bill, but I think it
Oh,
wound
yeah.
up being budget language. So
Oh, that's right. The primary care piece did go to, but we'll pull it out. Thanks for reminding me.
yeah, I think this is definitely would be a great subject for the committee to take up at some point during the
Yeah.
session. In my humble opinion.
It's a good opinion. I mean, humble.
Yeah. Another important part, or the backbone, I should say, of our workforce are the nurses. And so these are numbers that I pulled. I got this from also from the health department. We have our APRNs. So I have I show like how many licenses do we have in each of these categories of APRN, RN, LPNs, and LNAs. And so you can see they have the number of licenses in Vermont and then what percentage of those are actually practicing in Vermont. But also an important piece I added here was what's the average age? Again, so this gives you a sense of the workforce and what's the percentage of that particular workforce that's under 40 or over 60. And then also I threw in the piece about pursuing further nurse education. So folks that are RNs, LPNs, LNAs, what percentage are looking to continue to move up the nursing ladder? And then of course I have to put the year that the stuff was in. But this is sort of a snapshot of our workforce regarding nurses. And then I added a little note about PAs because when I did this in healthcare, someone said, well, what about physician's assistants? Aren't they important? And the answer is yes. I just didn't have any data on them, but they are an important part of our healthcare provider workforce. So I just didn't want to hear from the National Association of PAs like, you ignored us. Also dentists. This is 2019 data. We had 389 dentists, which translated to 289.3 FTEs. 313 provide mainly primary care. Again, I show you the ages, and you can see a large majority are over 55. But what I also found was slightly encouraging was that between 2017 and 2019, the net number, while the net number of dentists stayed the same, more dentists were providing 30 hours or more. So the dentists that we had were actually starting to provide more hours. I don't know if this is encouraging or whatever, but it was an important fact. And then also the percentage of dentists accepting new patients was 97%. However, the percentage of dentists accepting new Medicaid patients dropped to 55%. This is something I'm sure you'll hear about down the road about Medicaid reimbursements for dentists and what a barrier it can actually be to access to dental care. So I'm going to move on to payers, insurance coverage. Again, all these facts and figures are pre-COVID-19 data. I tend to think of things in three different ways. We have our private commercial. And under private and commercial, we have our employer-based and our individual market-based. And I will, I'll get into more detail of what those are. And then I break it down into government, which is Medicare and Medicaid, and then military, which is sort of its own thing. Now, when I talk about government, so for instance, when I talk about state employees, or teachers, which we think of as public employees, I capture them, or they're captured under the employer-based. So there's actually considered private commercial insurance, even though it's the public that's paying for it. It's still usually private insurance products. So when I talk about government, I'm really just talking about Medicare and Medicaid, and that considering like teachers' health plans or state employees' health plans as employer-based insurance, just to give you a sense of. Now that said, you can see that private insurance, half of Vermonters have more than half of Vermonters have some form of private insurance, but Medicaid and Medicare are still a big chunk of our healthcare system, and that our uninsured rate is actually 3%, which is was 3% Don't know what it is now, whether it went up or went down pre-COVID, but we do have one of the lowest rates, if not the lowest rate in the country. I know that we battled Massachusetts for being the lowest uninsured rate. What I like about this chart is that it's illustrative in that it shows that our number from 2000 to over the 18-year period between 2000 and 2018, the number of uninsured decreased. However, the number of private insurance also decreased. So uninsured went from 8% to 3%, but then our number of private insurance, people with private insurance went down from 60 to 53%. While in that time, you can see that both Medicare and Medicaid increased. So what we're seeing over that period of time is a shift. Now, what's causing that shift? Part of it might be that population, the age dynamic that I showed, demographic that I showed you earlier. Some of it might be expansions in Medicaid from the Affordable Care Act. Some of it might be the economy. There's all different factors. So when people say, what do you think those are? I think it's all of those and more. But nonetheless, it's an important piece because when we start moving into like our budget, it gives you a sense of what direction we're moving in. And I like this slide too. This is also from the Green Mountain Care Board because it gives you a sense of when you look at the types of services, what that government versus private payer mix. So for instance, you can see like mental health or home health, majority of there is Medicare, Medicaid funding. Probably a lot of that is, in particular nursing homes, most of it's probably Medicare and then Medicaid, but a very small private pay. And then you can see you start moving into physicians and hospitals. That would be like your doctors versus in your hospitals. It's about half and half between private insurance and Medicare, Medicaid. And then once you start moving into like dentists, you can see the majority of it is private and only a small piece of it is government. So you can just give you a sense of where our government or how the payer mix is across the different types of services.
Wait, Nolan, how can mental health be 100% government spending? There's private spending on mental health.
That's a great question. I'd have to look at the data dictionary from the expenditure analysis to see what they're including where, because it's possible that maybe some of the services that the DAs provide might not be in the mental health bucket. They might be in substance abuse. They might be in other services that they provide. But you're right. I mean, like for instance, if you go to your therapist, and you're a state employee, you're getting it through that. So that's a great question. I don't know where that would fall under, but this is, I should look into that.
Okay.
This is their document. All right, so I'm going to move into specific private commercial insurance. So this is sort of broken up into our employer-based and our individual market, and I just have a little note about military. So our employer-based is and I'll talk more about what self-insured is, but we have those plans that are self-insured plans versus insured. And a self-insured plan, and I do go into this 2 slides from now. So I'll go into a little bit more detail about what a self-insured plan is, but it's a designation. And then our insured plans, we have what are known as, these are kind of the markets. We have our association plans, which used to be a lot larger piece of the market. Now they're much smaller after the Affordable Care Act. Then we have our large group and our small group. Small group is actually defined in law. It's employers of 100 or less, or under 100. I forget if it's 100 or less or under 100, but it's around 100 or less. And then we have our individual group markets. So the small group, though, you break it up by a large group or small group or association. If you're an employer, usually these are employers, and it might be the type of insurance you decide to buy. That's based on whether you want to be a self-insured plan or insured plan, and then also in your size. If you're a big employer, you'd probably be a large group or self-insured. If you're a small employer, maybe like a lawyer's office or something, and you have like 12 people, you'd be a small group. And then we have our individual market. These are folks who do not have employer-sponsored insurance. And I'll go into more detail about these folks down the road. Actually, I'll go into a little bit more detail on all of these and our military. But this graphic sort of shows you the difference. Oh, the one thing I'll point out is in the chart, you'll see Now I have a little dotted around the individual and small market. Those are what we call merged, which means that they're pooled together into this and sort of have a larger, you may or may not hear down the road about having the size of your pool, insurance pool helps reduce the risk. The larger your pool, in theory, the lower the risk. The smaller your pool, if you have a pool of 12 and somebody has cancer and they have $250,000 in claims, it's going to be spread across that pool at a higher rate versus if you have a large pool and somebody has $250,000 in claims, it's going to have a smaller impact. So in theory, you want to have as large of a pool as possible. So these particular pools are merged in Vermont.
And Nolan, could you define association plans and maybe talk a little bit about why they've decreased?
So before the Affordable Care Act, associations, there would be groups of, and I would defer to Jen if she were here, but in short, there might be a group of, so for instance, the municipal employees used to be an association plan. And what they could do is they could, under the association would form. Now by law, they couldn't technically form for the sole purpose of creating insurance. They had to be sort of involved for something else. But as an association, they could pool people in. So if I were, let's say I'm going to make up an association, we'll call it car dealers, which I think there is one for car dealers, but you might have, 50 small car dealers across the state who have 12 employees each. But if you put those 50 employee organizations together, you can have a larger pool. And so these associations would offer insurance products to people in their associations. That's the high level version. There's all kinds of rules around them.
Nolan,
Yes.
Nolan, Dan,
Yes.
the big association was the Chamber of Commerce. And for
Yeah.
those that are on finance, pay a great deal of attention to the merged markets, the size of the pool. We spent a long time on associations and what they did to those merged markets. And in the end, the federal government, after allowing associations, banned them. So, but we're into a new world. But this is definitely an area that we spend a lot of time on.
Yes. Thank you, Senator Cummings. You said a lot of.
Finance is going to fix it for us, so we're all set.
Oh, yeah, right
And
away.
then what had happened was associations were banned and then they were temporarily allowed back and then not allowed. So there's this they're up in the air. I think there might, I think there was like where one, it might have been the chamber. I think they formed a new one, and then the law changed and they weren't allowed to, they didn't have to disband, but they couldn't bring in more people. So it's evolving, as Senator Cummings has pointed out.
Well, and I've also heard the rumblings out there that they're just going to be gone away. So we'll see what happens under the new
Yes.
administration.
Yeah, the point is that they used to be a really big part of, or bigger part of our payer mix or of our healthcare system, insurance providers, and then they sort of weren't, and then they started to come back, and they may or may not.
So I guess my question is, does that add to the uninsured?
No, because folks that were on association plans, they were when the associations disbanded, those people bought through the small group or other ways. They had other avenues. It was just that, if you're a small business, you're looking for what's the best way to get the best product and premium for my employees. And association was one option. And when that option went away, those folks can still buy a small group or through other options.
Thanks.
Good question, though.
So I'm going to ask one more question while we're looking at that pie chart together. And that is that we frequently hear a concern about how, I don't want to get into this discussion right now, but the differential between private and public insurance coverage for providers and the cost differential then causing the little cliff where money is transferred from private to cover public gap deficit. And then that raises a question about the total cost for uninsured and how they're covered. And that's something we'll have to look at ultimately. But I don't want to get into the conversation, but it does raise a set of issues. Sorry.
It's fine. The thing that's interesting though is that it does get into the conversation about pools and experience of that pool. Like if so, you know, the example that we used to use when the associations existed is if you had a pool of aerobic instructors and another pool of coal miners. Yeah, the pool of aerobic instructors are going to have a better experience, and in theory, they're going to have better premiums. So, I mean, those don't exist, but just to give you a sense, when you think about your pools and the experience of a pool, what that means. And so the question has often been raised, like, well, the state employees or the teachers, why are their premiums so much lower than folks on the large group market or in the small group market or whatever? And a lot of it has to do with the experience of the pool. And so when people say, well, we should let people buy into the state employee plan or teacher's plan or whatever, so they have lower premiums, it doesn't mean that those new people coming in might not change the dynamic of the pool. So just to give you a sense of the conversations around pools. And then of course, there's another whole other conversation about actuaries and actuarial values. And I won't get into that, but I do have a lot of actuary jokes that I'll tell you sometime, though they're funny. All right, on that note, so approximately half of Vermonters, like I said, it's about 53%, have private insurance. 90% of that chunk are employer sponsored, and only 5% are the individuals. So 90% of the 53% of private insurance are through employer sponsored insurance, and only 5% are in individual plans. And then of that 5% of the people that are in individual plans, 65% of those, or roughly 21,000 Vermonters, receive some form of state and federal subsidies through the state and federal government through Vermont Health Connect, which I'll talk a little bit about here. So Vermont Health Connect, I think you all know this, but I'm just going to preach to the choir here. It was established, these health benefit exchanges were established under the Affordable Care Act. Vermont, we call ours, Grizz, shh, sorry. We call ours Vermont Health Connect. It's an online marketplace for individuals and small businesses. Like I said, it's 100 or less. And we call it Vermont Health Connect. So this is the slide that I was going to talk to you about the difference between insured and self-insured. And what time are we at? We're at 9:45. Perfect. All right.
So Nolan, can you make the target 5 minutes of 10?
Yes, because I think that what happens is in the next 10 minutes, I can get through this piece and then stop right before we get into Medicare and Medicaid.
Perfect.
So I think this is perfect. I think that, and I think I can give you like a 5 or 10 minute break. Perfect. So just don't ask any hard questions and we'll get through this, people. All right. The problem with not being in the room is I can't hear you laugh. Everybody's muted. I look forward to us all being in the same room again. So, all right, on that note, the difference between insured and self-insured, and this is a very high level, we can start getting into conversations about ERISA, and if you do that, I'm going to call my lawyer, Jen Carby. But self-insured is basically defined by ERISA, and anybody who can tell me what ERISA stands for will get a gold star, because I never seem to remember. But basically the difference between insured and self-insured. So insured, the insurer bears all of the risk. So I'm an employer. I buy a private insurance product through MVP or Blue Cross Blue Shield. And so the insurer is bearing the risk. I'm just paying a premium every month. Where with self-insured, like I'll use IBM or the University of Vermont Medical Center as an example. They're a large employer and they say, well, or any large employer, they'll say, well, you know what? We have 1,000 employees and I think that instead of paying a premium on 1,000 employees, I think that we've got a healthy population. We could put in some wellness programs in places, and we'll buy gym memberships. We could do all these things to keep our people healthy. And I think in the end, if we just bear the risk and paying their healthcare costs, it'll be cheaper than buying premiums for all of them. And so what large employers, very large employers, most usually do this, and they'll do this, but they'll still hire what's called a third-party administrator, or TPA. And Blue Cross Blue Shield is a TPA as well. Cigna is a TPA. So like, for instance, I work for the state of Vermont. State of Vermont is self-insured. It's a slightly different designation because it's a public employer, but it's the same concept in that we're self-insured, but all of our insurance cards say Blue Cross Blue Shield on it, because we use them as a third-party administrator. And what the third-party administrators do is they adjudicate claims, they do all the administrative functions, and usually what they do is they actually have a product saying, we have all these different products as a third-party administrator, and people buy it, and then we just pay them an administrative fee to process those claims. So in the insured, like I said, the employer purchases the coverage from a regulated health insurance company. So that would be, Blue Cross Blue Shield or MVP, whereas the self-insured will purchase the third-party administrator or TPA services. In Vermont, the insured are subject to state regulations through DFR and other things. In self-insured, they're not subject to state regulations. This is where ERISA comes in. So, and I won't go into too much detail, but the example I will give is that when we used to do mandates prior to the Affordable Care Act, we'd say, okay, you have to cover mammograms or colorectal screenings. The insured products in the state of Vermont would have to cover those services. The self-insured did not. Most of the time they usually did or already did. And the state employee plan always usually did whatever they did anyway. If the state passed a mandate, they would usually just do it also. But they're under ERISA, they aren't required to. So that's one of the big differences, is that we don't regulate ERISA plans, which are self-insured plans, which there are roughly 177,000 Vermonters who are in self-insured plans, just to give you a sense of the size of this particular group. So that's the difference between self-insured, is we can regulate self-insured the same way.
A question that we may want to look at as maybe a little bit later is the number of self-insured plans that have fallen apart as a result of the pandemic. But that's not a question we need to look at right now.
Okay. So I can blow through these next slides pretty quick. Again, so our small employer plans, defined as up to 100 employees, there's approximately 41,000 people who are covered by these small group. You'll see the word QHP, which stands for a qualified health plan. It's just a term that's specific or created under the Affordable Care Act and has to do with the type of plans, and I won't get into it. And then again, many small employers some of them were in the association plans. I don't know what the status of those are. Again, just to highlight the individual plans, this is actually important because you'll hear a bunch about this as partially as part of the budget as well. So we have approximately 32,000 people, this is as of June 2020, that were on these individual plans, 2/3 of which were receiving some form of financial assistance. And in order to receive those, you have to buy directly through the exchange in order to receive those particular subsidies. If your income is too high to receive a subsidy, you don't have to buy through Vermont Health Connect. You can go directly to the insurers. But if you think that you are eligible for subsidy, you buy through Vermont Health Connect. So our federal advance, there's several kinds. We have our federal advanced premium tax credits, also known as the APTC. That's available for those up to 400% of federal poverty. Now, for those of you who have the slide, who have printed out the slide deck or have it pulled up, if you go to the very last slide on the last page, right before this says the end page, you'll see I have an FPL chart. And that'll give you a sense of when I say 400% of federal poverty, what does that mean? You know, so for a family of 1, it's 51,000. For a family of 4, it's 104,000. Usually what I do is in the committee, I have a giant FPL chart printed and I tape it to the wall so that people can turn around and go, oh, okay, it's $100,000, or that's what that means. So that's just as a reference. If you want to know what the FPLs mean, federal poverty level, those are set up by the federal government, and that's where you can find it. And for anyone who wants another chart, I can also email it to you. So you just let me know. So your federal advanced premium tax credits are available for those up to 400% of federal poverty. Now the state decided to offer additional state tax credits available for those up to 300% of federal poverty level. So I believe, so it's a sliding scale. So the federal government, it was a percentage of your income. It was between, I forget, 1.5% and 9% of your income as a cap. I forget off the top of my head what it was. And what we did as a state is we said, okay, take your federal, if you're under 300%, take that federal percentage of what the cap is as a percentage of your income that your premium can be, and we bought another 1.5% of that off. So if you were at an income where it was no more than 6%, you couldn't pay more than, you were capped at paying more than 6% of your income on your premiums. We'd buy you down to 4.5%. And for that particular piece, we get a federal Medicaid match. So that's part of the budget you'll hear. And the reason it's 300% is because the feds wouldn't let us go above 300% because we had to negotiate that in as part of our Medicaid global commitment, which I'll get to what that is, but we had to negotiate with the feds. And the reason they even let us do 300% was because we were covering up to 300% as a subsidy when we had Catamount Health prior to the exchange. And that was the high level, was for 300%. So we also have, there's also state and federal cost sharing subsidies. Now this is different. So the premium tax credits basically are on the premium side, and that's through it's a tax credit. So that's how you get it, is through a tax credit. But that was to try to limit or help subsidize people's monthly premium. The other subsidy is what's known as a cost sharing reduction. And essentially what that does is that tries to reduce people's out-of-pocket exposure. And so what it would do is it buy down some of the out-of-pocket, it would buy down some of the deductibles. And that gets into some of the more of the actuarial science. But it was basically, long story short, we were trying to, the federal government was trying to limit the percentage of, was trying to limit the amount of out-of-pocket cost exposure. When I say out-of-pocket, I'm talking your co-pays, your deductibles, your co-insurance. So, and then we, as a state, decided to buy down even more of those. Federal government would not let us use Medicaid match on that, so those are pure state dollars. I could tell you off the top of my head somewhere how much we spend each year in those, but I don't have it with me right now. But we do spend quite a bit. And so this slide kind of gives you a sense of the small group compared to the individual group. And you can see that we have the folks in the blue are receiving state and federal subsidies, and the folks in the yellow are the groups that receive no subsidy because their income is too high. And those folks they can buy directly from the insurers if they want. What time is it? Okay, we're getting close. We have our military. There's roughly 17,000 people in the state of Vermont that receive their insurance through the military. And then finally, just a very quick note, or two more slides. First, quick note about the uninsured. So according to the 2018 Vermont Household Health Insurance Survey, this is something as a committee we can go through at one point. This gives a really rich document that lays out different pieces of where do people have their insurance, who's uninsured, why are they uninsured, and it has a section on underinsured, which is a whole other thing. So it's a useful document for anyone who wants a copy of it. I can send you the link. It's a very, 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 very useful document. We usually
Nolan, why not send it to Nellie and let her put it under your name for our so we have that as a report.
Okay.
That'd
you know what I'll
great.
do is I'm also send the expenditure analysis. I think that
yes, that's good. I mean, any of these things that you think will help inform us, it would be great to have.
Yeah. Those
the
are two
committee.
really rich documents that if you have time to kill, because I know that since you're all just sitting around home not doing anything, it's a great document to read before you go to bed. So anyway, so we have 19,800 people, or 3.2% were uninsured in 2018, which was a slight decrease from 2014. So that means we were moving in the right direction. Now this is useful information, which is of the uninsured, 17% were eligible for Medicaid. So we have people that are uninsured and eligible for Medicaid, but just aren't enrolled for whatever reason, and this was something that was talked about a lot when we were rolling out the Affordable Care Act, is how do we get more, they did a lot of marketing, and there's just some people that are never going to enroll, and other people have other reasons. Now, that said, if Medicaid is kind of like an open enrollment in a way, and that if you're uninsured and you're rushed to the hospital for whatever reason, if you're eligible, they'll sign you up there so you can get coverage. So that's a nice thing about Medicaid. You don't have to be like, sorry, you're not enrolled, you have to pay for it. If you're eligible, they will, and by law, I believe, or the hospitals go out of their way to try to, like, oh, you're eligible. They try to help you sign up while you're there to help you get coverage if you are eligible. 43% of the uninsured were eligible for both state and federal subsidies. So these are people who are uninsured, could be getting subsidies on the individual market, but don't, most likely because they still don't want to pay the premium, because even though it's a reduced premium, it still maybe too much for them. And then we have 28% who have access to employer sponsored insurance, but don't sign up for it. So we can see that we have a chunk of our uninsured that have access to insurance in one way or another and still aren't signing up for it. And this is, through the years, has been a conversation of a lot of conversations been around that. And I'm just going to have one more slide and then I'll be done. And this is just kids. So this is just to show that we have a very low uninsured rate for kids. It went up. It was 1% in 2014, and now it's 2% in 2018. But it just gives you a sense of, like, we have a very low uninsured rate for kids. But we have 50% of kids in Vermont are on Medicaid. So in the far right corner, you can see just a comparison of the overall Vermonters compared to the kids. I just found this really interesting, and I just want to sort of flag that. And with that, I think that I will take a break, and it'll be a nice segue into the next section. So
Thank you. This has been a good start. A lot of work. This is the new and improved Healthcare 101. It's great.
Lots of practice.
Yes, no, thank you. So, committee, I know that Sarah Clark, Nolan, why don't you take, yeah, that's good.
Yeah.
I know Sarah Clark is here. We'll hold off a little bit until Mike Smith comes on with us. So let's take a little break. Let's take no more than 5 minutes. I'm going to just keep my eyes open. Nellie, you can help us with that. And then we'll start when Mike Smith gets here. But take 5 minutes, please. Nellie. Good morning, Secretary Smith. We took a little break in preparation for you, so we're all coming back together. Everyone should be here in no longer than a minute. Gave them
Okay.
5 minutes. Sarah, good morning.
Good morning.
So why don't we get started and welcome Secretary Smith and CFO Sarah Clark. Thank you for being here with us. And I see that you did provide us with an organizational chart, and I'm really pleased you did that. I actually went out online last night looking for a comprehensive organizational chart for AHS, and the people I ran into have moved or in a different slot or no longer there, and then it was all broken up in bits and pieces. So this will be great for you to give us an overview of AHS, and then I'm sure we'll have some questions for you going forward. So I'm going to turn it over to you, and Sarah, let you go ahead with the presentation that you have. And thank you.
Well,
I think
thank you.
and one question, do you know everyone on the committee? Because we do have committee members who are new.
I don't know everybody on the committee, actually.
Let's do this very briefly then, committee members, and we'll start with Ruth. Just your name and your district.
Thank you. Good morning, Mr. Secretary. I'm Ruth Hardy. I'm a senator from Addison County.
And actually, Ruth is also our new vice chair.
Oh, great.
Yeah. Cheryl.
Good morning, Cheryl Hooker, Rutland County.
Ann. You're still muted, Senator. You're
Too many screens going here. Secretary Smith and I have known each other for a long time.
and our new clerk, Josh, go ahead.
Good morning, Secretary Smith. Josh Terenzini, Senator from Rutland County.
Great. Nice to meet you, Senator.
We're overwhelmed with Rutland, but we can handle them. They're good people.
We have to
Yeah, between Addison and the committee sort of leans towards that portion of the state. Thank you so
Doesn't
much.
it? Yeah, I know.
So, Madam Chair, thank you so much for having me today. I'm quarantined, so I am here because you may have read that some of us are quarantined, including the governor, from our weekly press conference. So I'm speaking to you like thousands of Vermonters have had to do, staying at home downstairs. The rest of everybody else is upstairs, and this is my living arrangement for the next 7 days. So we'll continue to live like this. I do want to thank you very much. For the record, I'm Mike Smith. I'm the Secretary of Human Services. I want to thank you for the opportunity to be with you and to talk about the agency. I'm pretty proud of the agency. I mean, as you know, the Agency of Human Services has a large portfolio and a mission, but to this, we're here to help Vermonters. And as you had heard me, especially Senator Cummings and Senator Lyons has heard me say before, it's probably my greatest honor in my career, and I've had multiple careers, but it's my greatest honor in my career to sort of lead this agency. This is the second time, and it is, it's the most fulfilling job that I've had. I have the opportunity to lead an agency that does really great things, and to be associated with about 3,500 people who work every day to help Vermonters. And you've heard me say this before for those who have been here, but let me just repeat some of my background and why I think it's so important. You know, in my younger day, and when I was going through high school, um, I was not the best behaved kid, I guess, is what I want to say. In those days they would describe me as a juvenile delinquent. But the, the issue of behavior at in that sort of, I was always constantly in trouble, whether it was in school or elsewhere. The family life was unraveling primarily because of my father's alcoholism that became so excessive. He finally drank himself to death. Um, we, I've been homeless in my younger day. Not that I was on the street, but that I was, going from couch to couch of friends' houses and things like that. And I've been broke. But throughout that whole time, I also had family and friends that I could rely on, that I could turn to, that I could get some sort of help or at least guidance in terms of what's going on. A lot of Vermonters don't have that. And we are that at the agency. And we have been that since this agency has been formed. And like I said, it's a huge agency, 3,525 employees, $2.6 billion budget broken down into 6 departments. And then, of course, the secretary's office, as we have talked about before. And I'll just give you a flavor of what we're talking about in terms of the different departments. We have the Department of Vermont Health Access, which its responsibility is basically to administer the Medicaid health insurance program and the Vermont's state-based exchange health insurance program. It is a fairly significant department in terms of all funds. For example, DEVA, in terms of all funds, is about $972 million. So the Medicaid program drives that. It's a fairly substantial program, as you will discover. The Department of Health, which has been sort of the lead department in the pandemic response, its mission is pretty simple, is to protect and promote the health of all Vermonters. And, it has 12 district offices. In order to do that, we'll be utilizing those district offices for the vaccine distribution here very shortly. It has a budget of about $163 million. The Department of Mental Health, whose mission is to promote and improve the mental health of Vermonters. And it has, the Vermont Psychiatric Care Hospital. It has the Middlesex Therapeutic Care Residence as well. And the Department of Mental Health has a budget of all ins with all funds of about almost $278 million. And then we start getting into the Department of Children and Families. And the Department of Children and Families is a huge department in terms of people. It has a child development division. It has an economic services division. It has a family services division. It has an office of child support, has an office of disability determination services, and it has an office of economic opportunity. And if you look at DCF, it has a budget of about $425 million. And then we talk about DALE, which is the Department of Disabilities and Aging and Independent Living. And its focus is on making sure that Vermont is, and it's ranked one of the best state in which to grow old or to live with a disability with dignity, respect, and independence. And And Dale's budget is about $532 million, all funds included. And then the Department of Corrections is probably the only one that's mostly general fund as we look at the Department of Corrections. And I want to talk about the Department of Corrections a little bit. You know, we often talk about what it does, and we talk about that it operates an integrated system of incarceration and field supervision services. We operate, correctional facilities and 11 field supervisory offices. It has a budget of about $168 million. Most of it is general fund because it doesn't qualify, most of it, for federal funds. But it's more than that, I think. We've got to realize that in corrections, we have a responsibility of returning people successfully to life once they leave corrections. And we're starting to look at this some of you remember back in the mid, I think it was 2005, 2006, we started a program called the Incarcerated Women's Program. And what we did is brought the whole agency together to surround people, women in particular, that were leaving the correctional facility with a lot of services so that they would succeed. Many of these women had burnt their own bridges during the time preceding their time incarcerated. Many of them had no family support. The family had left them in a lurch. We found that when we did that, we had a much greater success rate in making sure that they didn't return to prison. We're starting that process again at the Department of Corrections because I've seen it work, and I think it's important as we move forward. There's been a lot going on in the last 12 months at AHS. Obviously, what's taken a lot of our time has been the pandemic response. First, at the first wave, with stay home, stay safe, getting up the testing capability where we have 19 permanent test sites now throughout the state. If you want to get a test, you can get a test. I have to get tested once in a while, and I can easily register for a test throughout Vermont. Not only that, but now we're seeing vaccine rolling into the state, and although it's a lot less than we expected, we are prioritizing those individuals that are more susceptible to death or hospitalization because of COVID-19. And so you'll hear from me tomorrow talking about the fact that we're going to be opening up registration on the 25th, which is Monday, for those that are 75 and older to get them vaccinated. There's about 50,000 Vermonters that we will start opening up registration for. We anticipate that will take about 5 weeks in order to do. We only have 8,800 doses of vaccination coming into the state each week. So we anticipate that will take about 5 to 6 weeks. But you'll hear more about that tomorrow as we sort of roll that out and how people can register, where they can go to register for their vaccination and move forward. There's no surprise. It will be similar to the testing system where you centralize, where we have a centralized registration system. It will direct you to the nearest sort of vaccination center and have slots open for you to register as you move forward. I'll stop there. I'll answer. We had a reboot of the all-payer model that I can talk about if you'd like. We saw some things happening with the all-payer model that we thought needed to be addressed this year. And so we took a really critical look at where we are and where we're going with the all-payer model. And what we decided is that we needed to make some changes, both at AHS, with the ACO/OneCare, with the Green Mountain Care Board, and with our federal partners. And we looked at that very, very carefully and did a report that we'll try. I'll make sure you get. But we basically said we have to change. We have to change at the ACO level. We have to change at my agency's level. We have to change at the Green Mountain Care Board, and our federal partners have to change some things as well. So that report was done at my wish. I thought we just needed to do it and move forward, and so we'd be more than happy to come back at a later time and talk specifically about that report as well. So in terms of
Secretary Smith, just on that issue, we have invited Ina Backus in, and it might be appropriate at that time. It's up to you if you'd like to come in with her as well, but to give us an overview of, and I could see you're just dying to come back, but so, no, seriously, so we'll have Ina come in and give us the all payer model 101 and the report that you're talking about. It's a good step, I think. So it's important for us to see it.
And lastly, Madam Chair, because I started out talking about Rutland County, I was born in the old Rutland Hospital, so it really weighted now towards Rutland County.
We're surrounded.
That's I'd be happy to answer any questions that you may have.
I have one very discrete question in the beginning. I missed the total funding for the healthcare reform, Department of Healthcare Reform, or it's actually in your office. So is that part of the part of your administrative piece?
You mean Ina Backus's?
Yes. Yeah.
We'll get that to you. I don't have it off the top of my head.
Probably not significant at this point.
Yeah. Just so you know, Madam Chair, we have moved the responsibilities. It's not in the budget because we're going to do that next year, but not 22, but 23. But we've moved the responsibilities of both the blueprint and HIE into the Director of Healthcare Reform's portfolio.
Well, that's terrific. I did know about those changes, and we should have we may have a further conversation, maybe offline, just to get up to speed a little bit and some ideas. So let me ask a couple of questions, and then we'll turn it over to members of the committee to do that. If you don't, I'll just get us started. I noticed in the organizational chart that the trauma person is not in place, and I know that we lost that person, but it seems to me in the middle of the mental health and substance use disorder surge that we're seeing with the pandemic, that could be a really important position. And so just maybe an update on where you are with that.
Yeah, Auburn left that position about a week or two ago, I think it is now. We plan to recruit for that position as soon as possible. And we aren't going to eliminate that position. We're going to keep that position, and we're going to still have it in the secretary's office. So just to give you a heads up, but we are going to be recruiting for that position.
Well, that's helpful. We will invite members of the Prevention Council, the Chief Prevention Officer, and the Trauma Officer in from your office to get an update on prevention generally and what work is being done. So please, just please keep us informed about who might be able to speak to that when we
Right.
get there.
No, and she did a wonderful job. She just unfortunately for us, she found a dream job that she wanted to go to. So
That always gets in the way of life, doesn't it? Yeah. I
it's-
know. Okay. So I guess the general question is around staffing. And I know that during the pandemic, a number of folks have been moved from one office to another, or position to another, to cover some of the pandemic needs. So 2 questions about that. Number one, will some of the anticipated new federal funding cover some of the costs? So if there are available people out there, we can hire temporary folks. Is that possible? And the second thing is, given the really extraordinary amount of work that the agency does and each department does, it would seem to me there has to be some sense of loss, and some of the work may or may not be getting done as well as it was pre-COVID. So I'm just looking for your response, I guess, and your thoughts on that.
well, let me in terms of staffing, we've been very good at using coronavirus relief funds in a way that allows us to staff up and staff down when we need extra help in various areas. And we've been able to use federal funds, for example, with the vaccine program, as we ramp that up and use various assets that we have throughout the state in order to do that. So I think in terms of staffing, we've been pretty good at ramping up in those areas we have to ramp up in, and maintaining in areas we have to maintain. I've got to tell you, I'm pretty proud of the agency. I think we've done a pretty darn good job at keeping our core mission and responding with our core mission as we deal with the pandemic. Certainly, people have been pulled out of various positions to deal with the pandemic, but if you look at some of the things this agency has done, first, we basically shut down an outbreak in our correctional system. And now other states, and in some cases countries, are looking at how we did that, and how we move forward on that. Second, this isn't sustainable, and it's probably not the best way to do it permanently, but we virtually eliminated homelessness in this state during the pandemic. And now I will readily admit that's not sustainable as we move forward. We did not let our child care system collapse during the pandemic. Many states let their child care system wither during the pandemic. We did not do that. We kept the child care system fully subsidized during the pandemic, and in actuality, for people that needed childcare, we subsidized on top of that some of the childcare needs, to the point of about $45 million that we have done. So we've done a lot of stuff during the pandemic that we normally wouldn't do. So we've not only maintained what we've done, but expanded some of the things that we normally wouldn't do.
So, and along those lines, one of the things that our committee is really very interested in is filling the gaps that have been identified through the pandemic. So you mentioned childcare. That's a huge priority for us, and we will have folks in from CDD and others to try to sort out how to fix a system, if you will. And there are other parts of the human services system that need some work. So I'm thinking just in terms of what we've discovered during the pandemic. that's, that's true for healthcare as well. So hospitals and providers, and how important the all-payer model has been for that. But it would be extremely helpful for you to help us develop the appropriate policies or recommendations. If you can provide us with some recommendations, through your commissioners or others, that we can then work on together. I know we've worked pretty well in the past, and so we have to keep doing that. This pandemic is not over. But when we come out of the pandemic, our goal is to come out better, and we will continue to work on that. I think that is a goal of the Senate in particular. So that's all I wanted to say. I'm gonna let others ask questions, and I do hope that you continue to test negative.
I did last night, so just so you know, I will continue. I have another one tomorrow.
Okay. And I want to circle back after everyone's chatted, and I might get into some corrections healthcare questions with you. But so, questions committee. Senator Hardy.
Thank you. And thank you, Secretary Smith, for your overview. And a lot of my questions, I think I'm going to have to wait on, because they involve plans that I know that the governor may or may not be unveiling. And I'm just very curious about those. So we'll definitely have to have you back. And also I think your agency in particular may see some very positive changes given what happened yesterday in Washington. So I'm really optimistic, trying to be as optimistic as possible about the future and what we might be able to achieve together. I know that the governor is constantly talking about protecting the vulnerable as one of his 3 pillars or priorities, and your agency certainly is. That's your job for the most part. So I'm grateful for the work you have done during the pandemic in particular. I wanted to ask you about vaccinations, of course, because that's on the minds of everybody. And I know you're going to make some announcements tomorrow, but of course, we're all hearing from constituents about it. I continue to be really frustrated that not all of our long-term care facilities have gotten vaccinated, not even their first shots. I know that personally, so it's frustrating and scary for those of us who have loved ones in long-term care facilities that have not gotten vaccinated. And I talked to the commissioner about that when he was in, Commissioner Levine, and I just urge you to put any more pressure you can on those private pharmacies that are in charge of that, because they're not doing a very good job with it. And then I also, I know that the bans are age-related bans starting with 75 and older. Will that include Vermonters or people who are incarcerated? Are you also going to be doing those age bans in our prisons and other residential facilities? Because people in residential facilities of all kinds are a big concern of mine, because once it gets into one of those facilities, whether it's a nursing home or a prison or a mental health facility, it's just incredibly hard to control. So that is my question right now. And then just, putting a pin in all of the budgetary stuff, wanting you to come back and talk to us about that.
Yeah, let me, there's a couple questions in there that I want to answer. We have vaccinated all skilled nursing facilities once, and they should be done by the end of the month, their second dose. All residential and assisted living facilities should have their first dose done by the end of the month as well. Some their second dose as we're moving forward. We have been urging the federal pharmacy program to speed it up as we move to the to the next phase, which is the age banding phase that we talked about. If you are incarcerated and over 75, if you are in any sort of, if you are a Vermonter over 75, you will be vaccinated in this next age band, wherever your location is.
Does that include the out-of-state prisoners as well that are in, was it Tennessee?
They're in Mississippi.
Mississippi.
Senator, I will make sure that happens. I know that I've seen the list, and it's like there's 5 in Springfield and 5 in Newport. I will make sure that I see the full list.
Okay, thank you. Yeah, I think that that's really important that we continue along those age bands in all of those facilities. So I appreciate that. We have that as a priority.
And Senator, thank you for that, because where we've been seeing the vast majority of the deaths are in that 75 and above age band. And 65 and above is where you are the most vulnerable, but 75 and above is where we've seen a lot of the deaths recently.
Yeah, I agree. I think the age makes sense. I did say to the commissioner, and I'll say it again now, I think all of us are hearing from teachers and childcare facilities, et cetera. And I believe that those employees need to be prioritized if we are starting to look at employment groups. And I just caution you and Secretary of Education about opening schools full-time without having all of those people vaccinated. I understand the age banding, but I would just urge you to be really cautious about moving forward with reopening more things before everyone can be vaccinated.
Okay, any other, so I see Cheryl Hooker, Senator Hooker has her hand up, but I do want to say something. I was going to say this generally to the committee earlier regarding all the requests we're getting from teachers and schools, but and Secretary Smith, maybe you can elaborate a little bit on the administrative nightmare of trying to deploy vaccines by occupation.
Yeah, it is. It's the one thing that we found, the data, we were pretty data driven on this and looked at what our prime objective is. And that is A, to prevent death, B, to prevent hospitalization. And we found that the age banding was the best way to do that with a limited supply that we have. I will share with Senator Hardy's, I'm hoping that there's more consistency coming from the federal government in terms of what we're seeing, because it's been, I kind of describe it like this. It's been, you're having a dinner party, but you don't know how much food is coming and you don't know when the food's arriving. And it's hard to plan like that when you're doing that from week to week as you're moving forward. But we found that the data supported the age banding, and if you went with just what the CDC called essential workers, everybody could be described as essential workers. And so you're not strategically doing your vaccination program that really has an impact on reducing death, reducing hospitalization, and really at that point, if you can do that, starting to reopen your economy and starting to recover from your economy, versus if you just have everybody, it's sort of scattered and there's no plan on that. And we just felt it was going to be chaotic and divisive in how we were going to move forward. So we came up with this plan. It was different than what the CDC recommended, but nonetheless, we thought it was science-based and reflective of what we were seeing in the data.
All right, thank you. Thanks for that reminder. Senator Hooker has a question.
Thank you, Chair Lyons, and thank you, Secretary Smith. I have a question regarding vaccines. I appreciate the science-based approach that's being taken and the banding. So when the dosages come in, and as of the 25th, people 75 and older are going to be able to receive the vaccine. Is it guaranteed that those people who already have had the vaccines will get their second dose? Or is this going to be the first dose, first dose people first?
Well, we've made a commitment, and hopefully the federal government will keep its commitment that those that have first dose will get their second dose, and we are getting second dose in at the same time. When I talk about starting these bans, I'm talking about first dose. We are anticipating that the second dose will come in through the pipeline. It is now. I don't want to scare people. We are getting second doses in. But we have an allotment of first dose each week of about 8,800 that we're planning on coming in for first dose. We're planning that the federal government will, through its supply chain, continue to bring in the second dose along the way. We've been assured that that second dose will come in. At the same time, I just want to, I've been rocked a couple of times by what we've been told and what has actually happened. So I want to be cautious in saying that, but so far, so good. We've seen the second dose come in at the appropriate time.
Okay, thank you. And, we did have Dr. Levine in for a very long period of time. And I think he actually said all of these things, but sometimes it takes a lot of repetition to build the knowledge. And we appreciate your taking the time to reinform.
That's fine. And frankly, Madam Chair, it does change. We're
No
fighting the
kidding.
federal government.
Yes, well, it will change now radically, let's hope. Senator Terenzini.
Thank you, Senator Lyons. Secretary Smith, I was going to basically bring up the topic that Senator Lyons did with teachers. I think maybe I hear about it more than some because I have school age kids and drop them off many mornings. And since I became a senator, teachers love me now. I don't get it, but anyways, I'm glad that you and the governor and Dr. Levine are at least understanding the concerns that educators do have, and why they feel that they certainly should be moved to the front of the line. And we know in a perfect world we would have plenty of vaccine for them and everyone else as soon as possible. I actually it's funny you mentioned the second vaccine, because I had someone ask me the question yesterday. I didn't know the answer. Not to get too scientific here, but is the second vaccine, the second shot, is it the same formula as the first, do you know, or is it a different configuration or different potency in the second vaccine?
Yeah, the one thing that can get me in trouble real fast is trying to answer things that Dr. Levine should be answering. But let me just say this. If you get the Pfizer the first shot, you should get Pfizer the second shot. The potency of it and the booster aspects of it, I'll leave to Dr. Levine to sort of walk you through what it is. But you need the second shot to complete the process in terms of getting to the in Pfizer's case, the 95% efficacy level that we need. So I will leave it at that.
Thank you.
Okay, any other questions? I do have a couple more. One question relates to the caregivers at home. So during the pandemic, we've seen a number of folks who have been really isolated and having to care for family members or others at home without being able to access outside health care or support. And I think of people who have with disabilities and so on. And I don't remember honestly how we handled that or how that was handled during the stabilization process, and how that if funding is provided for those stay-at-home caregivers. And I don't know if either you or Sarah can weigh in on that one.
Yeah, I'm going to ask Sarah to weigh in on it. I think we took care of, well, we take care of them through the process through Dale, but can you elaborate on that, Sarah?
Yes, sure. For the record, Sarah Clark, Chief Financial Officer for the Agency of Human Services. When Commissioner Hutt and I were in, I think it was just last week, we talked a little bit about some family support stipends that were issued to the developmental services community in support of exactly what you're referring to, Senator Lyons. So I think that there have been supports provided to families that are at home dealing with family members throughout the pandemic.
Good. And I think I noticed in the new federal funding that there's provision for that group of folks again, but at the federal level, which I'm not positive on that, but I think it may be reassuring, but it may also be very targeted to reduce flexibility. So I don't know, but that's an important, talk about the most vulnerable. There they are. And my other question is on foster kids and how they're faring. And when we have DCF in at some point, we'll be able to ask this question again, but I didn't know if either of you had some comments to make about foster children. I know the age change, but yeah.
Yeah, I mean, it's been difficult for everyone through this pandemic, and foster kids are no different than some of the other challenging populations that we've had. I will say that the foster care program has weathered this pandemic, and in some cases, I think DCF is probably can sort of elaborate on that. But during the pandemic, the foster program, as didn't dissolve, didn't collapse, didn't probably struggled like everything else that we have during this pandemic. But I haven't heard of anything that would cause me alarm in that program. Whereas, Senator Lyons and others will remember in March and April, I had a real fear that the health care system was going to collapse. And, we sort of talked about that and worked together to make sure that didn't happen with the stabilization reserve, in some cases, helping what we just talked about, those independent families. But I haven't heard of that situation happening in the foster care program.
Yeah, so yes, and as you're talking, I'm thinking about the age out provision, so that now kids who are 18 and older can, I forget how many years they can stay with families, but that for me, that's something to think about, how to reduce that cliff for kids so that they have some support as they walk into the real world.
Yeah.
So our committee will probably talk about that. We'll try and get someone in from the agency.
Senator, I hate to keep going back to ancient history, but I'll do that. But I remember in it was 2005 or 2006. We had a foster kid summit, and we brought the foster kids in, and we said, "What do you need?" And what was amazing to me was the things that we heard. We heard things that we would have never thought of, like we need help getting a license because we don't have access to insurance. We don't have access, one foster kid turned to me and said, are you at 18 going to tell your daughters to leave the house and be on their own? And of course, I said, no. And he said, well, that's what happens to us. So, that really had an impact on me. And I may do that again, just to forewarn you. I was planning on doing it before the pandemic. But as soon as we get ourselves out of this, I may do that again because it was so helpful. We filled the well of the house with people, which you can't do right now.
Right. Well, and now you're going to get stories about, excuse me, stories about what actually helped and what needs to be perpetuated, I guess. Senator Hooker has a question.
Senator, you're on mute.
You're still muted. Senator Hooker.
Yep, I'm there.
There you go. There you go.
Thank you. I applaud the efforts of the agency on what you did with homelessness at the beginning of the pandemic. It was phenomenal. Can you give us an update now on, I know that at one point there were over 2,000 people, if I recall correctly, in hotels. Can you give us an update on that? And, what do you see as the things that have happened that have really ameliorated that? And also what's necessary going forward?
Yeah, we still have 2,000 people in hotels and motels. The fact is the resurgence in the what's happening across the country, and again, Vermont is the safest place, but nonetheless, we still have a resurgence going on. Last night we had 102 cases, 3 deaths. We have this situation going. We have to keep people off the streets to keep them safe. It's not, and you've heard me say this before, I'm not a big fan of the motel hotel program because it just puts people in, feeds them, and sort of it doesn't provide enough support and permanent solutions to the problem. We can't sustain this. As soon as the feds are paying part of this hotel motel program, it's very, very expensive. I think, don't hold me to this, but I'm just going to give you these numbers to give you some proportion. We've gone from like 5 million, 4 million for a hotel motel program to 10 times that amount in terms of paying for that program. That's just not sustainable. We had planned to transition out of that program and move to a community-based program. Some of the things that DCF had talked about before, we had to suspend that for a little while, but we'll be coming back to you in this session and talking about the time schedule once we start seeing some break in the pandemic of moving this into a better local program. We also have been very aggressive with using coronavirus relief funds in building permanent housing. I want to eliminate family homelessness. And if we can move as many people into permanent housing, families into permanent housing as possible, I think we have an opportunity here to do that. A lot of coronavirus relief fund has gone into building and having permanent housing. I think that's a real objective for us to look at and move forward to. But we still have about 2,000 in motels, hotels right now.
And I appreciate your comments on permanent housing. And I know that in Rutland, we've done some of that, but that takes time. And I know that the urgency of this situation is something that, permanent housing isn't going to affect right away. But thank you for your comments.
Right. And I know that this committee did some work with the VHCB to try to identify housing needs, and hopefully we can access some of those funds going forward, especially when CRF and new federal dollars disappear. But Josh, Senator Terenzini, you have a question?
A question or comment, Senator Lyons. I appreciate the topic of homelessness coming up. It's certainly important to me and all of us, I would venture to guess. Senator Hooker and I had the opportunity over the last several months to be a part of a transitional housing or bridge housing in Rutland County. And I'm glad that we were able to see that through, Senator Hooker. The problem that I see with it is, I was just astonished when you mentioned there's 2,000 people still in Vermont who are living in hotels. This facility, and Senator Hooker can correct me if I'm wrong, but this was at least a couple $1 million build using CARE coronavirus money, and it's only 9 units. So you think about 9 units for $2 million, and then you say there's 2,000 people still living in hotels. I mean, the number is daunting. I mean, it's beyond imaginable what it would take to take all those folks out of those hotels and put them in a nice facility like we just saw built in Rutland Town. So I don't know if I have a question, but it's certainly a comment. I think it's a discussion worth having at some point, Chair Lyons.
Yeah,
We'll do that.
yeah, and I think DCF will be prepared to come in and talk about how we transition to sort of the local program that we had originally thought about before the pandemic hit.
So I'm just wondering who that would be that you would recommend we bring in from DCF.
I would think Sean Brown and Sarah Phillips.
Well, okay, all right. So Sean is the right one. Okay, that's good. We will do that. Senator Hardy.
Yeah, I just want to, since we're talking about housing, I think it would be great to work on that with our Economic Development Committee, and Senator Hooker has a nice connection with the two committees. And just Senator Terenzini, I agree, it seems extremely daunting. A lot of times though, the housing is transitional, and it helps people to get back on their feet and then get into their own housing. One of the best stories I've heard about this housing program during the pandemic is this family I know who has been perpetually homeless, and they've been in this hotel housing throughout the pandemic, and it has helped enormously, especially the kids during this crazy hybrid schooling, and to be able to have a safe place. And just talking to one of the kids about how comfortable the beds are in the hotel and how meaningful that was for him, so it's a great program, and hopefully families like that will be able to transition into more permanent housing after they've had this stable housing.
Okay, I have another question, and we're starting to run out of time, but I did want to ask you, Secretary Smith, we worked so hard on keeping our business of healthcare afloat, not just hospitals, but clinics and then independent providers. And I guess my question is probably not a simple answer, but how many providers have we lost as a result of the pandemic? I know you've done it. Before we finish, I just want to say what an outstanding job the whole agency has done. We couldn't be the best state without the work of AHS. Just no way. Department of Health has received the lion's share of attention, but it's everyone. So, but in terms of the independent providers and others, what do we see for healthcare losses?
Yeah, I think they were minimal. I think there probably were some. I don't have the numbers, but they were minimal. There would have been a lot more had it not been for the stabilization funding program that we had we collectively worked on together. I think that helped stabilize the system to the point where we weren't worried about it collapsing. We weren't worried about people going out of business. I can try to find out those numbers, Senator Lyons, but I can generally say with confidence that it was minimal.
Okay. That's good to know. I mean, because first of all, I think some of the providers were very reluctant to come forward, and concerns about being able to reopen practices. So, that would be good to get caught up on that. Committee, any other questions while we have Secretary Smith here? Senator Hooker.
Just going back to what Senator Hardy brought up about kids in hotels and being in school. I'm just curious to know how the department has handled. Have you felt that you were able to adequately provide broadband for people, whether they were in hotels or, any other situation, during the pandemic? Did you get enough help that you needed? And are there gaps that we need to fill in that respect too?
Senator Hooker, there's always one question that I have no clue to. This is one of them. I will find out for you. I don't know the answer to that. I would assume that I have not heard of issues dealing with broadband or issues dealing with with broadband. So let me try to get back to you on that.
There's the question of the day. Thank you,
There we go.
Senator. Any other questions? So I want to thank you both and for being here. And I'm sure we have 1,000 questions, and it's just great that you have been able to share an hour with us. We understand the complexity of your schedule. So thank you.
Thank you. Thank you very much. I really appreciate it.
Thank you. All right.
Thank you. Be safe.
Bye.
Okay, terrific. Thanks, committee. And, I think I think you have identified again some of the issues that we want to dive into, and we'll do that. So take a little breath. Do we want to just stand up for 1 minute? Nolan, would that be okay with you? No? Okay, I think everyone you can turn your video and your sound off and just stand in place. We can come back. We'll just see how many people were actually standing in place. Cheryl and Nolan and I were. Aha.
I was standing during all of Secretary Smith's testimony.
Oh, you're lucky.
Stamina.
I was more like pacing.
I need to get a desk that raise my computer up. Can do that.
I took a table from my deck furniture. Standing at that.
All right. Okay, so we are back, and Nolan is here. And Nolan, maybe you can point us to the slide that we left off, where we left off, and we'll continue. And before we do that, Senator Hooker.
I'd like to go back to where we were again. And Nolan, we talked about kids that were uninsured. Why
Okay.
would any kids be uninsured? Can you explain that? I mean, I thought we covered all of our kids.
You know,
I
there
can
we
answer
go.
that.
Oh, can you?
I think so. I just know that some people don't enroll. That's all. But
I mean, the way I saw it is, wow, we only have 1,000 or 1,200 kids uninsured, and you see it as like, oh my gosh, we have 1,200 kids uninsured. So, which is probably the better way to look at it than where I was at.
It makes sense that some people just wouldn't enroll, but are there ways that we have
There's
enrolling?
just some people that you'll never. I don't think it's possible to ever get to 100%, unless you just
they
did.
may have coverage that they use, you know, for
Those
their,
probably, yeah, those
family.
are probably the parents are probably uninsured, and
Yeah.
for the same reason that they're uninsured, their kids are uninsured. It's a great question, and I don't know the answer.
Thank you. But I think it was a little disturbing that it's going up, and that's,
Yeah.
it's gone up.
Not. Yep. All right. So the transition, I'm going to talk about Medicare and Medicaid. I'll start on Medicare with the preface of that I'm not going to spend a lot of time on it. I'm not an expert on it. And also the fact that the other reason I'm not going to spend a lot of time on it is that while it's a big part of our healthcare system, it's not one that we as Vermont, you as legislators have any say over. You have say over Medicaid. You don't have any say over Medicare in terms of our legislative authority laws. So before I start, though, I always have to do a quick note about Medicare versus Medicaid. And so there's the difference between the words themselves are two letters. Medica, then you have aid or air. And so as a result, people conflate them all the time. I was in this presentation yesterday and I kept saying Medicare. Oh no, Medicaid. So like it's just very common, but they're very different. And the big difference between them is that Medicaid is a state federal program. So as I was saying, is that this is something that we as legislators have some say over in terms of the budgetary process, in terms of laws and other stuff. Medicare is a pure federal program. We have no control over it whatsoever, with the small caveat of that there's a thing called an all-payer model, which I'll get to at the end. Medicare is involved in that, and so that's like the one sort of exception in which we have some more interaction than normal with Medicare. Also, the eligibility structure is very different. So Medicaid, designed for low income. Medicare is all incomes. Medicaid is children and adults and 65 or older, blind or disabled, where Medicare, again, is all incomes. You have to be 65 or older, or any age if you have end stage renal disease, or if you have certain disabilities. So the eligibility structures are very different about who's covered. And then, of course, there's a whole thing about Medicaid expansions, but I just put that as a note because it came up in the presentation I did the other day, the House Healthcare, where someone asked, well, what about the expansions? And I just sort of felt like a foot, but this is like the main difference between the two.
Is there a difference in the revenue source for Medicaid and Medicare at the federal level?
How do you mean?
Well, is it all from payroll deduction
Oh,
for both programs? Do we know that or not?
I don't know the answer to that.
Okay. Yep.
Yeah,
Don't
sorry.
need to go there. I just curiosity.
Yeah, sorry. So real high level, it's a federal program, no state role at all. It was created in 1965, and in many cases, it's privately administered. We have roughly 120 to 130,000 Vermonters, roughly 20%, who are on Medicare. So it's not an insignificant number. Nearly everyone of those are over 65. Only 1,700 or 1% of those are younger kids or younger people than 65 because of the other things I talked about, certain disabilities or end-stage renal disease. And then there's some parts that have some additional requirements, but I'm not going to get into that. I put a little note that the number of Medicare beneficiaries increased by roughly 9% between 2014 and 2018. So again, think about that demographic chart I had on the beginning of the presentation. That's a big jump in a 4-year period.
Cummings has a question.
Oh,
No, I don't have a question. I just have a put things in perspective. In 1964, I was on a high school debate team, and the topic for that year was a federally sponsored healthcare program for those over 65. The standard objection was that would be socialism. So just put things in perspective as to where we've come. I bit my tongue and never said, so what? But I was tempted. But anyway, that was the big concern, that this would be socialized medicine.
Right, we were still very much in the Cold War and everyone afraid of communism and everything else. Persists today.
so again, I'm not going to get into the weeds, but Medicare has 4 parts. There's Part A, Part B, Part C, and Part D. And again, this is more of a reference slide. I won't get into the difference of each of those. I'm going to jump into Medicaid. So Medicaid, also created in 1965, it's a public health benefit program for low-income individuals and families with and individuals and families with disabilities. It's financed through a federal-state partnership, and it's administered by the states. So each state designs and operates its own program within those broad federal guidelines. And the joke amongst Medicaid nerds is that if you've seen one Medicaid program, well, then you've seen one Medicaid program, because that they are all very different. And if we were all in the room together, this is a part where you would all be rolling on the floor in laughter. I'm just kidding. So nationwide, there's 75.5 million people who have coverage through Medicaid. This is approximately 23% of Americans. Now, this is a point here in Vermont that I always try to make. Sometimes in the media or in the news, you'll hear 1/3 of Vermonters are on Medicaid, and it's actually not true. We have approximately 182,000, or 1/3 of Vermonters, receive some form of assistance through Medicaid. Now, the difference is you have folks who have it as their primary source, and that's roughly 22%. So that's more like, a little over a quarter, right? Who have some form of, who have it as their primary source. Those are the folks that are on Medicaid. So when you hear 1/3 of Vermonters are on Medicaid, it's actually not true. It's more like a quarter are on Medicaid. And then we have another, what's that? Center lines?
Never mind. I was thinking 22 is closer to 20, so it's more like a fifth. So anyway,
Yeah, it's like
I was being
fifth.
picky. I was being
know.
fussy.
That's what I thought you were making those hand signals for, but I was
Yeah.
just gonna, don't challenge my math. No, I'm kidding. And then we have another 48,000 that have some other form of partial or supplemental relationship with Medicaid, and so our coverage. And those would be folks like we have a program called VFarm. So there's a prescription drug assistance program for folks who are on Medicare Part D, low-income folks. We have that also would include folks who are who have a premium assistance or cost sharing assistance through the exchange. So those folks are not on Medicaid. Those folks have private insurance, but they're receiving supplemental or assistance from Medicaid. So again, with the Part D would be their coverage of Medicaid. So those are folks that are not on Medicaid, but they have some form of assistance from Medicaid. So that's a big difference that I like to sort of highlight. Medicaid, there's who is covered and what is covered, and I would I'm not an expert in this area. It's so easy to sort of go down a rabbit hole of what about this person, what about that person, and I'm not the expert on that. I will just say that off the bat. But I did want to, but it's important to sort of like cover this at a high level. And so, who is covered? This is our eligibility, and in order to qualify, beneficiaries have to be a state resident. They have to be a U.S. citizen, permanent resident, or a non-citizen with lawful presence. Their financial situation will be characterized as low income or very low income and be one of the following: pregnant, responsible for a child 18 years old or younger, blind, have a disability or a family caretaker of someone with a disability, or 65 years of age and older. And again, these are low income and those things. Then we have our what is covered. These are our benefits. And under Medicaid, states are required to cover certain mandatory benefits and then can choose to cover some optional benefits. And I'll actually just jump ahead to this slide. This is an example. So the purple on the left, those are the services that under Medicaid we have to do. And that would be inpatient, outpatient, nursing facilities, home health, physician services, et cetera. These are services that under Medicaid we have to, if we're going to have a Medicaid program, we have to provide these services. Then we have the optionals. These are the ones where the federal government's like, you can cover these, it's up to you. And these sort of, this would be prescription drugs, chiropractic. I feel like dental falls into there somewhere, maybe. I don't see it. But again, so these are and I, as an aside, whenever there's deficits in Medicaid in the past, I always get the question well, what are our levers? What can we cut? Or what, and there's only a small limited amount of people that we would be allowed to cut under our thing. And then these services are the services now these services aren't a lot of money. The big money ones are the inpatient, outpatient, all the ones on the left side, the ones that we're supposed to cover. Those are the big money costs. So on the right side, if you cut those, you're not saving a ton of money. So, so chiropractic services will be an example. I think since I've been working at the legislature, it's been added, it's been cut, it's been added, people want to expand it. That's a perfect example of a service that we can choose to do it. Of course, these are our optional services. I'm not saying that you should cut anything. I'm just using it as an example of potential levers that we have or things that we can control. A real side note about dual eligibles. I'm not going to go into super detail about these folks, but these are folks that are both on Medicare and Medicaid. So these are lower income folks that have Medicare and are eligible for Medicaid. Medicare is the payer of first resort. And so earlier when you saw I had the chart with X percentage of people were on Medicaid, X percentage were on Medicare, these folks would be counted in the Medicare box, the Medicare bucket. So they get Medicare covers, and then Medicaid is sort of like the second coverage. But the flip side is, so there's not a lot of people. There's 18,000 people in Vermont that are these dual eligibles. However, this is an example that you may hear in our healthcare system of a small population that costs disproportionately a lot of money compared to the size of their population. And this is the number one. You can see here, AHS or Vermont spends over $220 million per year on just these 18,000 people. And that's because they're very high needs. So it's a very expensive population. And, usually they're high needs, they're older, they have a lot of conditions. So this is an example of that. And by the way, there's a lot of DVA and HS have a lot of programs in place to try to work and help contain the costs of those particular populations. So they get a lot of focus and a lot of attention. Overall, now this is the part where I start getting into the numbers. I'll start real high and I'll just sort of work my way down. So at the high level, in 2018, Vermonters, we spent $6.26 billion on healthcare. I say it's projected to be as much as 6.65 in 2020 because that was the estimate. We won't know for 2 years what 2020 actually was, but this is the estimate of what it was. And of which 27% of the total spending in the state was Medicaid. So if you recall, we said 22% of the population has some relationship with Medicaid, but it accounts for 27% of the spending. And so I got the question later in House Healthcare the day, well, why is that? And again, that would go back to the same thing about there tends to be a bit higher needs amongst folks in the Medicaid population, and particularly duals are counted in this category. So they would help weigh off, help explain part of the cost in that. And we also provide services for people who are blind and disabled. So Medicaid is a service that provides services for those with high needs. As a result, it's going to be more expensive. So forgive this chart. I always have to beg forgiveness for this chart. This is a Steve Klein chart, and then I took a Steve Klein chart and then I put two on one page, so it makes it even more confusing. But I just want to highlight, we're going to focus on the colors and not on the words. And so if you look on the left side, so this is the total state budget in 2019. I used 2019 because at the time I put the slide together, I didn't have a full 2020 chart. So I just used 2019. But it's really more illustrative to give you a sense of how big Medicaid is as part of our budget. So in fiscal year 19, our total state budget was $5.86 billion. Medicaid accounted for 30.3% of the total budget. Now, this is our appropriated budget. These are all funds, state, federal, all funds. So you can see that so Medicaid's in blue, and the only part of the pie chart that's bigger is the pre-K to 12 education. Now, if you go to the state funds, which is the sun on the other side, this is just the state dollars. If you pull out the federal dollars, our of the fiscal year 19 budget, 2.75 billion were state funds only. And you can see that Medicaid is the biggest part of our state dollars. So it's 26.26% of our state dollars, which is slightly above the pre-K education dollars. So this shows you that Medicaid is a huge part of our state budget. Total Medicaid expenditures in 2020 were 1.83 billion. So again, this is gross. When I say gross, this is state and federal combined. So our total Medicaid appropriation was $1.83 billion gross. Now, this does not include any of the COVID-19 federal dollars that we've been receiving. This is this is more of our base funding. I didn't add that in, just I didn't have the data to do it at the time. And it's beside the point. I want to show people a sense of just sort of how the Medicaid funding works. So our pre-COVID-19 split of state and federal dollars is roughly 40-60%, 41% state dollars, 59% federal dollars. Most, not all, but most of this federal dollars come in the form of what is known FMAP, Federal Medical Assistance Percentage. This is a term that you will hear a lot about. FMAP, Federal Medical Assistance Percentage. So what is FMAP? So FMAP is the share of state Medicaid benefit costs that are paid by the federal government. So this is their share of it. Most of these federal dollars, most of the federal funds for the state Medicaid fund are FMAP. I just said that already. So the way the FMAP is calculated by the feds, and it's based on a 3-year average of state per capita personal income compared to the national average. Now, the formula is actually more complicated than that, but roughly, I won't go into the weeds on that because I don't know them, but that's essentially how it's sort of calculated. And what's weird about that is that you'll see, and I'll show you in a future slide, our FMAP kind of fluctuates. It goes up, it goes down, and it changes year by year. And so one year, if our FMAP goes up, that means our federal percentage of federal dollars go up. So for every dollar we spend, we're getting more federal match. Flip side is when our FMAP goes down, it costs the state more state dollars to provide the same level of funds. So it works for and against us on many occasions. The flip side, though, is that when our FMAP goes down, which means that we have to spend more state dollars to provide the service, it actually means that we're doing better at personal income per capita. So it's a double-edged sword. So when our FMOP goes up and we're getting more federal dollars, we're like, yay, we're getting more federal dollars, but it's a sign that our per capita income might be decreasing. So something to keep in mind. So before you go, yay, we're getting more FMAP. Oh, wait, that's because we're not doing as well.
And so there's no relationship with health outcomes.
Nope.
Nope. Okay.
It's tied to and it's a 3-year average. So but yeah, there's not tied to health outcomes at all. So no state can receive less than 50%. So it's capped at 50% or more than 83%. And so I have here is a chart that just sort of shows various states. I have all the New England states, and then I compare like the states that are high FMAP and low FMAP. So the low FMAP states are all the ones that are just sort of locked in at 50%. And those are generally your high per capita income states, your Connecticut's, New York, New Jersey, Massachusetts, Colorado, California. So those are states that have high per capita income, and they're at 50%. And then you have the ones that have the highest FMAP. Mississippi has the highest FMAP, 77.76%. That's huge. And then you can see it in New England, just kind of where we sit compared to other New England states. 3 are at the max. Rhode Island's 54. We're at 54.57, and Maine is and the little arrows mean it just increased or decreased from the previous year. So, and just as a side note, these particular FMAPs are a federal fiscal year. So the feds they're calculated on a federal fiscal year, and in future slides or when you hear from Corey from Medicaid or whatever, and they might throw out a different FMAP than what I'm putting on this presentation. That's because these are federal fiscal year FMAPs. For our state budget, we actually have to convert it to the state fiscal year. So we take 3/4 of one and 1/4 of the old one, and we kind of blend it together, and that's how we come up with the FMAP. So the FMAP that we use in our state budget is a blend to make so that it corresponds with the federal fiscal year. That's just sort of an aside. So if people wonder why that it doesn't match, that is why. Now those are we have 3 different FMAPs. We have our base FMAP, and then we have 2 other FMAPs. And actually, I'll just move on to the next slide here. So our base FMAP, so these are the state fiscal year FMAPs that I was talking about, so we have, and this is the majority of our FMAP. So it's 54.39% federal, 45.61 state. So translated, for every 1 state dollar, we get $1.20 in federal money, and we get $2.20 in gross. So for every 1 state dollar, it buys $2.20 in gross services. So with our children's health insurance program, it's roughly 70-30. And then for the childless new adults, this is an expansion population under the Affordable Care Act. We get an enhanced match for this particular group. It's about 35,000 folks. And this is a 90-10 match. So for every $1, we get $10 in services. So the thing about FMAP is it's a double-edged sword. So for every $1 in state dollar, we get $2.20 in gross services. But when we cut $1, we're cutting $2.20 in services. So if you cut $1 million out of the Medicaid budget, you're really cutting $2.2 million of services out of the system. Vice versa, when you add $1 million, you're adding $2.2 million. So it's a double-edged sword. It can work for us and it can work against us. Usually it works for us. It's a good thing. Now, as an aside, under the Federal Families First Corona Response Act, I think this was the first COVID bill. I think it was the first COVID bill. So this is the CARES Act, I think, was actually the third COVID bill. The first COVID bill included a 6.2% FMAP bump on the regular FMAP. So this is an additional 6.2 to the 54.39%. This was part of the helping the states manage the pandemic. Now, 6.2 might not seem like a huge jump, but translated into state dollars, that has been roughly $22 million per quarter. So for the full year, for 4 quarters, we've received $88 million in additional states federal dollars just for the Medicaid program, which is not insignificant. Now, the way it works is that we get the 6.2% for every quarter for which the federal public health emergency has been declared. So, and according to Sarah Clark, who was testifying the other day in one of the committees, she said that they heard that we will definitely get the 6.2% now, at least through June. So we know that we're going to be getting another, $44 million. So, and I think that's going to be, you'll see that reflected in the budget. We don't know going forward if we'll continue to get there, how much longer. I mean, hopefully the public health emergency is not going into the fall. So we can only hope. All right, global commitment. This is really going to be your first brush at it. The goal here is to sort of just kind of give you a high level explanation of what it is, and try not to go down too many rabbit holes because we can easily get lost in this. So basically, much of Vermont's Medicaid program is administered through what we call global commitment to health. Medicaid has, in the Medicaid law, there are these things called Section 1115 waivers. It's in the Social Security Act. And what it does is it allows the federal government to waive many, but not all, of the laws that govern Medicaid, including those that are related to eligibility and services. And what they are basically is they're demonstration projects that are agreements between CMS, the Center for Medicare and Medicaid Services, and individual states. And I don't know how many states have them, but I think it's at least more than half, if not more, of states have some kind of Medicaid waiver with the state. And you can have more than one. Vermont right now, I believe we only have one waiver. We've had, at one point, we've had 2 or 3. Choices for Care was another one, but that's actually been rolled in to a global commitment. The idea behind these waivers is really intended to encourage state innovation. So, and really when they say encourage state innovation, they mean save money. And so basically the idea behind it is that if the state can find ways to save money and obviously improve outcomes, that's the idea behind it. So that's the ultimate goal. And so states often will say, well, we think we can save money and we want to use those dollars to expand services or expand populations, expand eligibility, use dollars for Medicaid, or use dollars for things that traditionally can't be used Medicaid dollars for. So that's the idea behind the waiver. And every waiver, if you've seen one waiver, you've seen one waiver. And what I'll say about global commitment before I jump into details is that global commitment started, I believe, in 2005. And it's the most recent will be renewed, I think, at the end of 2021 or 2022. I cannot remember off the top of my head. But every time we renew, we have to renegotiate. So even though it has the same name and it's technically the same waiver, the global commitment of 2005 is very different than the global commitment of today. It's kind of evolved, both with a combination of what the needs are for the state, how the needs of the state have evolved over time, but also so have the administrations. I mean, it started under the Bush administration, and it's moved ever since. So, George Bush, Bush too. So to give you a sense of like it's moved through time through different administrations, and different administrations have different goals. When negotiating, when coming up with an agreement with them, there's usually what's known as terms and conditions, and in those terms and conditions, there's sort of like it's basically the contract of what we can and cannot use those dollars for, and with these waivers, they have to be budget neutral. So how do you define budget neutral, especially when you've had a waiver for going on 15 years? And so that's actually it's sort of a negotiated agreement. So the idea is there's a cap on our waiver, and the cap is what we think we would have spent in the absence of the waiver. And so the idea is there's what we think we would have spent in the absence of the waiver, and then hopefully we achieve savings. And then in there is that money that we save is money that we can use for things that we don't usually would not normally have Medicaid spending on. So for instance, we have these things called investments. Over the years, they've had various terms. They used to be called MCO investments, but now we just call them investments. And in 2020, we had 69 investments worth approximately $124 million. And maybe I'll have this Nellie post this too. I have the most recent. There's a whole list of what those investments are, and they range from all different things in DCF and Dale, mental health department. Like I'm looking at, there's things for WIC, there's things for tobacco cessation, there's things in poison control. There's mental health stuff. So there's a whole list of things. And there's 69 of those investments worth about $124 million. In the absence of this waiver, we would either have to cut $124 million of these things, or we have to find $124 million. So these are things that we can use Medicaid dollars for that we would not have been able to use. So this is where the innovation comes in. This is the idea, like we think we can provide services to this population in a way the federal government feels is appropriate, and use those savings for other things. So that's the basic underlying premise of what global commitment is. I'm trying to think if there's anything else on this that I wanted to say. No. Oh, I will say one more thing on this. There used to be, because I get the question on, do we think we're going to ever hit that cap? You know, the cap, the idea of if we hit the cap, which is what, you know, going past the budget neutral piece, what happens? If we go over that cap, Medicaid becomes 100% state dollars over that cap. Now, we've never really come close to hitting that cap. Recently, we kind of did, only because in the past years, we were able to sort of carry forward our money and carry forward the cap. And so in the earlier years, we had so much room that we were never really worried about hitting the cap. Then the federal government started clamping down, saying, no, we got to get the cap to something more realistic. And we've become much more closer, or accountable, I should say, to that cap. Now, I don't think there's no worry at this point of us hitting that cap, because AHS does a very good job of managing and making sure that we build our budgets in a way that we don't generally hit that cap or come near to that cap. Quick note about the all-payer model. You're going to be hearing about this next week from Ina Backus, who works for the administration. If she's watching this, she probably doesn't know she's going to be doing this testimony next week. So, Ina, you're on notice. But basically, and I'm not the expert on this, so I will defer to next week. But again, this is part of our healthcare system, so I wanted to touch upon this. And basically, the all-payer model, and I have to do this aside, is that people call it the all-payer waiver. It's not a waiver; it's a model. The all-payer model is an agreement, again, between the Center for Medicare and Medicaid Services, Agency of Human Services, and the Green Mountain Care Board. Those are the three signatories on the all-payer model. The purpose of it was to move away from fee-for-service reimbursement on a statewide level. And basically, one of the things that it does is establishes annualized limit of 3.5% growth per capita healthcare expenditures growth for all major payers. And all the payers are involved. So Medicare, commercial, Medicaid, and so everybody's involved in this. There's all kinds of outcome measures that have to be met, so that they're not just like, not rationing care. It's to ensure that like we're achieving those savings, but still maintaining high levels of services. Now, if you are, and this is where you'll hear about an organization called OneCare, or the Accountable Care Organization. They're the ones who are sort of implementing this with the guidance of AHS and the Green Mountain Care Board. If you are a person whose live is, we call it, attributed to the all-payer model or to the ACO or OneCare, you won't notice the difference. It's really more on the back end of how the service is provided. But beneficiaries, in theory, won't notice the difference. You'll still go and get your care. Your bill will still be the same. You're not going to get charged extra. It's sort of how it's really about trying to change the incentives and moving away from fee for service, which encourages utilization versus more of an outcome based. And this is the model in which it's going to be doing it. Now, you'll be hearing about the details of, is it working? Have we been hitting our targets? What's the future of it? How long is it? Will we renew it? Et cetera, et cetera, et cetera. You will hear about that next week. But I wanted to sort of lay the groundwork so you have a sense of what the all-payer model is. I think I have another slide on this. Okay, yeah. So on the outcomes, it looks at not just curbing spending growth, but also it looks specifically at health improvement goals, such as improving access to primary care, reducing deaths from suicide and drug overdose, and reducing the prevalence and morbidity of chronic disease. There's a lot of pieces in there. There's a lot of targets in there. There's no financial penalties to the state if we do not meet these targets, but obviously it's in. No, I won't say that. So the duration of this agreement was January 1, 2017. It's set to expire December 31st of 2022. The year 2017 was year 0. So this was a 5-year agreement, but this is year 0. And that was the year we were establishing a baseline. Now, of course, with the pandemic, everything is sort of in flux, and all the targets and all the numbers and targets and outcomes and everything were based on sort of trend and existing what we knew. And the pandemic has sort of shaken up that whole thing. So you'll hear about like, what does that mean for us meeting our targets? What does that mean for the future all-payer model, et cetera, et cetera. The pandemic has sort of shaken up the world as we know it. And that'll be one of the things or one of the questions you could ask next week when you hear from them. And then finally,
and just another comment on that, we will hear about the next steps that are being planned, but we won't hear that next week. That'll be later in the session.
Yeah, because the big question will be, did it work? Did it achieve its goals? Do we want to keep doing it? And if so, what would it look like if we do decide to do it? And for anybody who wants to sort of dive in deeper, I have a link to a useful summary of what it is. This is a link to the CMS website. It kind of gives a nice outline of what the all-payer model actually is. And then just to sort of wrap things up a little bit, we have our regulators, which are Department of Financial Regulations, who oversee, and in terms of insurance companies, they look at solvency, so they have a role in it. We have the Green Mountain Care Board, which does hospital budgets. They regulate our insurance premiums. They do certificate of needs, which is basically, oh, actually, you heard from the Green Mountain Care Board yesterday, so I don't need to do this.
Well, just one comment, though. Department of Financial Regulation does look at insurance company solvency with respect to the rates that they charge.
Yep.
And so their role is pretty significant. The Green Mountain Care Board then evaluates those rates and says yes or no. So, but that, just as a heads up, I think the difference between what DFR is doing and Green Mountain Care Board is doing when they look at hospital budgets and rate setting there, and then private insurance, there are a lot of questions in that about lack of alignment within the whole rate setting environment. For me, that is hugely problematic, and it's not a simple question. So just wanted to raise that as an issue.
Yeah. And with the Green Mountain Care Board, I've heard things from both sides. I've heard like, well, you have the Green Mountain Care Board, which is doing healthcare reform, and they're also regulating, and that's in conflict of interest. Or I've heard people say it was deliberate because you want to control costs and you can do it through regulation. So that's a philosophical argument, but it's an interesting point. Then we have our Attorney General's office, which does a lot of fraud or looks into fraud. Health Department does inspections. We have our Center for Medicare and Medicaid Services. And then these other are just non-state things, but these are regulators. We use the Joint Commission. They're stuff that sort of credential hospitals. We have our National Committee for Quality Assurance, NCQA. This is actually more behind the scenes stuff, but a lot of our models and stuff look at those from the quality improvement standards. So they play a role. And then I'll skip this slide because you guys, like I said, you heard from the Green Mountain Care Board yesterday, right? Kevin Mullen. So, and that's it. There's my FPL chart, and this is the end. And with 17 minutes to spare, so we have time for questions or You guys can go to the bathroom and breathe.
Not yet. Questions? Why don't we, unless someone is going to have a question around one of the slides, why don't we
Yeah.
get back together and then see if anyone has a question? And Senator Hardy, go ahead.
Yeah, thanks. Nolan, I tried to stop you at this point, but I didn't speak up quick enough. When you were talking about the global commitment and you were saying whether or not we are reaching our cap, do you mean the cap of the amount that the feds will pay, or what specifically the cap were you talking about?
Okay, so a good question. So the idea behind it is that we would be budget neutral, so that the state will not have spent more money under the waiver than we would have in the absence of the waiver. And so there's an actual amount, which I don't know, is over the period of the waiver, saying the state will not spend more than X billion dollars. And so the idea is that we will not spend more than X billion dollars, because then we would have violated our budget neutrality and therefore gone over the cap.
Got it. Okay, thank you.
And we got close.
Well, yes and no.
But
There's
tell us about that.
Well, so there's actually two caps. One is we were with the investments. Like I said, we've spent 124 million on investments, but at one point we spent a lot more, and we were I don't know if I find the right word, generous or liberal in our interpretations. I don't know what you want to call it, but we spent more on investments. And the federal government in the last agreement said, no, you're going to start lowering them, and you're going to lower them by X amount each year. So they put caps on the amount of investments. So we were getting really close to going over our investment cap. That was the bigger worry. We were really never a big worry that we were going to go over our budget neutrality cap, although we may have come, I say may because I'm not 100% sure, come closest to that ceiling than we ever had, but I don't think that we were actually ever really in likely to go past it.
Okay, thank you. Thanks for that. Senator Terenzini.
Thank you, Senator Lyons. Nolan, in your first hour of the presentation, way at the beginning, you had shared a few of the medical centers that had seen patients from New York and from other places, and if you remember that. I was surprised that this is a Rutland specific question again. Unfortunately, I'm sorry to the committee, but that Rutland Regional, being that we're only 20 minutes from the New York border, do you know, does the Rutland Regional Medical Center see a high uptick in New York residents or patients? And then my second part of the question, maybe it's not for you, but do we see a lot of non-payers because that part of New York sort of is a lower income, sort of an area that's struggling economically?
So good question, and I don't have the answer because that gets into specific levels of data that I don't have information on. The Green Mountain Care Board would, because they're the ones who look at hospital budgets, and so they can look at the payer mix, they can see, okay, we're getting this much Medicaid, they'll know what their bad debt is, or uncompensated care. So I unfortunately cannot answer that question. Doesn't mean that I don't think it's a great question.
No, it's a good question.
Thanks.
And actually, when VAS, we have the Vermont Association of Hospital and Health Systems coming in next week. And we can ask that question. You can ask that question again. And then when we bring, remember, I think we had talked with Green Mountain Care Board yesterday about providing us with some information on the hospital stabilization, financial stabilization report that we'll be getting. And we can ask for an update on hospitals that were in financial jeopardy. And then your question about who are the new patients, or, what are the pressures that have been applied to the financial stability? Those are good questions. So we can follow up with those when we get those folks back in. And FYI, the Green Mountain Care Board has a huge amount of information on its at its website, and that does include hospital data. So if you have, with all your free time, Josh, you can.
What
uh, Go ahead,
so
sorry.
no, and a different note, I will send Nellie a link to the investments because I know people always want to see those, what they are. So we'll send, she's already posted the 2 other documents that we talked about, and I'll send this one. And 2, I will put out this invitation. Threw a lot of information at you guys, and some folks are newer to this arena than others. And so there's various levels of understanding. I will volunteer my time to work with any of you individually as needed. We can do one-on-ones to sort of help you get up to speed. I feel like a big part of my job is helping you guys have the information you need to make informed decisions. So I'm offering my services. Reach out to me. I'm happy to sit down and work with you and help get you up to speed, or if I don't have the answers, which is often the case, help you find the answers you need or guide you to the people that would have them. So again, I feel like it's my job to help you guys have the information and tools you need to make the most informed decisions possible.
Well, thank you for that. And I do know that as we go through policy decisions, and whether we're looking at bills or being creative in our thought, that you are always available. So it's very helpful. So I encourage everyone to talk with Nolan.
And listen to my jokes.
Yeah, and his dog.
My dog.
Any other questions for Nolan? Well, in the tradition of health and welfare, we are finishing early. And it's really because we work hard when we're here. And I appreciate that. I appreciate all the attention that you've been giving to folks today. So we will end our live stream, Nellie, and we've finished for the day. So see you all tomorrow morning at 9 o'clock.